patient is a 72-year-old lady, hypertensive, diabetic, obese, and osteoarthritis. She came to me with class 3 symptoms of dyspnea and chest discomfort. General examination was normal. ECG was non-specific STT changes. 2D echo was, everything was normal, no wall motion abnormality. And this was an angio. We directly taken her for an angiography. There is a mid-ostial tight stenosis, focal stenosis. You can see just below the diagonal. And diagonal also looks some irregular, some mild disease, but in a elevocaudal you can see that there is a significant disease in the diagonal also. So the plan upfront, I decided I will do the by a 2-stent technique. Since both the vessels are a normal size, equal size, then I thought I may probably do with a DK culotte in this case. But only thing is on a short LED, proximal to the diagonal. That is only the disadvantage, whether I am able to achieve the part there or what. So the plan was to go for the double stent to a 2-stent technique with a DK culotte, then wired both the lesions and started dilating within a 2 mm balloon, 2 into 12 mm balloon. I dilated first diagonal, then the LED, and we achieved a good result. Then there was little haziness was seen in the diagonal, but probably that may be a dissection. Then took a 2.25 stent into 12 and was deployed in a LED, LC diagonal, and proximal part was done with a 2.5 mm balloon. And up to that, everything is okay. Now, patient started chest pain, ECG changes, and hypotension. This is the graph on the left side, right side is in a pre and the left side is in afterwards symptoms. Now, this is what is happening. Next shoot. Now, I place a stented diagonal to the LED. Now, there is no flow in the main artery. Hypotensive, ECG changes, and blood pressure slowly going down. So now what are the options we have now?
Yeah, otherwise it'll...
Now I don't know whether it's a dissection flap, dissection was created, or there is a thrombus is entered inside. Now, I didn't know what to do. Now the only wire is there, that is only the rescue for me. Now whatever I have to do with the help of the wire only now. I heard this, there is a jailed wire technique in the side branch. If the wire is there, as long as the side branch, if the side branch is closed, throw the wire under the struts, you can take your balloon, rescue the bar. Then it came to my mind, I thought that why don't we rescue same pattern to the main branch?
So why didn't you just try a new wire and just cross the struts and dilate?
We don't know, no, I'm pending. Dissection is there, then you'll aggravate again.
But this is just a carinal shift and
stent,
causing...
No, there is a stent across the diagonal to the LED.
But that is the first step you have to cross, no?
Correct, but now how do you, if there is a dissection flap closed LED, how do you go into rewire?
So actually the jail
point. Ready, you cannot presume and assume until you try.
No. He's got a point, because if there is a dissection flap and he could continue to expand the dissection, so imagine the roles reversed. Imagine this had been the LED and you had lost a large diagonal and you wanted to salvage it. You could probably use the same wire, go under the stent with a microcatheter and salvage it.
You can.
I understand.
But see,
Santanu, patient is symptomatic, hypotensive, chest pain, you can't keep on pedaling, no? You have to establish the flow.
Out of 10 cases where the diagonal has closed down, is your upfront choice first to use a microcatheter behind the stent? You'll first naturally try to wire, no?
No, behind the stent, microcatheter
closes, you don't have a dissection 15 millimeters beyond the closure. You normally have a problem right there. So if you have a problem right there, you can still wire it.
But
Here the ostium was
thing is,
open. See, if you see the ostium of the diagonal was, the LED was flowing. So it was not occluded exactly where the
no, the
stent
thing
is.
is
Simple
that
thing. This is
you have-
happened after pod balloon. This is canal
Yes.
shift. Your pod balloon has gone little bit into the branch, and that might have caused the canal shift.
No,
Yeah,
it's
I think
not
most
canal
likely
shift,
reason is
no.
that.
Listen.
No,
Ek minute.
it's not a,
Ready,
beyond see
ready.
that.
Can we go ahead?
See, the thing is that
Now, now
No,
what
so
I did,
the-
this is a technique, what this,
no. So the thing is that you can see if you go back, yeah, you can see that the stent has been deployed across the LED, right?
yes,
Yeah, and there's a portion of the stent which is in the proximal uh,
it is
LED.
an LED,
Yeah,
main,
proximal LED. It's in the
Yes.
proximal LED, which is open. So that area is not dissected because it's stented.
beyond that I'm talking about, beyond the diagonal, distal, mid LED.
Go
Now
ahead,
you go ahead.
Go ahead. Maybe
Now
we'll have to-
this is what I learned, I heard this way, then I have to do the same thing. Then took in the lowest possible balloon available, 1 mm balloon, passed over the jailed wire, and under the, but I not kept anything on the stented segment balloon. Ideally, you have to put the stented segment balloon to avoid the damage to the stent. But in this case, I don't want to do, because first immediately is rescue the LED, because she is hypertensive, crashing. Now pass a small balloons, gradually upsize, then it was planned to, then I crushed that stent with a larger balloon. Okay?
You're not doing a kilo,
No,
you're
I'm not
doing a
doing
crush.
Crush. I changed
And
it.
you're
a huge
changed to a
crush,
crush.
not even a mini crush.
Now after that, now flow is started tickling up the flow in the LED. Now the flow is established, patient become hemodynamically stable now. Now this stent, since the stent already crushed there, now it is become a classical crush, because quite a large part of the stent I have to crush. Now, my plan was to now this to convert into the DK crush. Instead of DK cullot, now it became a DK crush. Now I rescued the patient now, then afterwards it got into problem. Now the step crush was done, and sequential crush was done. You can see that the proximal part of the stent is adequately crushed. That is very important now. The recommended is a sequential crush, and a larger balloon is a crush is very important. Otherwise, while rewiring, it can go into the, in between the two layers of the stent. Now, after that, try to take the material into the main LED, but it was not going. I have to use an anchor balloon to support in the diagonal branch. So, distal, since the stent plan was to stent only the LED, but I have to change my strategy now. I deployed one small stent about 16 mm, 2.5 into 16 mm in the distal LED, beyond the mid segment. Now, then did a kissing, and stent was optimized, and this was a kissing of the branch. Now you can see that they are adequately flowing in the LED as well as in the diagonal blood. Now the plan was, since I handled very badly and the segment of the LED was not adequate to take the stent and do the part there, now I have to change my strategy from doing a LED to LM, because I don't know how much segment I'll get, because there is a trauma with proximal part of the LED, and it appears there is some plaque also there. Then I decided to take the stent from LED to the LM. Accordingly that, I taken the stent. Then stent was not going, I put the same anchoring balloon, and endocrine stent was positioned exactly. And now here, see, without realizing that there is, sorry, go back, without realizing that we deployed the stent, the balloon was caught in the diagonal. Yeah. Can you show
Pull out the
slides?
anchoring balloon.
Can, now I got into problem. Now somebody has to save me now.
You have Dr. Trihan's number. Phone a friend.
No, no. Now the balloon is there in a diagonal.
So
Now I deployed the stand.
most of the time this will come out. The only thing you will require is a brute force, and when you are applying a brute force, you will be careful that you are not injuring the inlet of the stand. It will come out.
Then I don't
In
know.
fact, if one technique is a JBT, where you deliberately jail a balloon, that's known as a jail balloon technique. There you leave the balloon just at the site of the stand. Your balloon is too far deep.
Too far.
So if you leave it, if let's say your balloon was partly into the LED and partly into the diagonal, then there was no problem. Then you just inflate that balloon and keep squeezing your balloon proximally and come back. But even this balloon will come back unless you have done a part and you have gone for a very high pressure dilatation. Because just deploying a stent and having a jailed balloon there, it can still come out. The only thing is force required will be more.
Now this I don't know. My technique is my technician is sat down. He told I can't do anything. Now you send her for an operation.
Operation.
No, there I don't know what I have to do. Now one thing I realized
At
that
what pressure did you deploy the stent?
deployed nominal pressure.
What,
Because
what is a
it is-
nominal? 6, 8, 10, 12 or
This was a
20?
12.
12.
3.5 mm.
For
balloon I
practical
take,
purposes, this balloon will come out. The only thing is you will have to apply a brute force.
Yes.
And while you're applying a brute force, you will also have to apply a counter traction. Once you're applying a counter traction, you should be careful that you are going to injure the inlet of the stent. So these are the consequences. And in case you want to avoid that, then you can take it out, because in any case you cannot use this balloon. So you have to cut the shaft of the balloon and advance a guide extension over it.
Yes. Luckily, this is what happened now. Then I decided I will wait for that. I thought I don't want to remove the stent balloon. Let the stent balloon inside the stent. Whatever may be, in case I will try to pull the balloon. If suppose if the stent get distorted, then I have a stent balloon inside, I can recorrect.
Yeah, that's important.
That is very important.
Then I decided that I kept the stent balloon there. Then this is I kept there. You can see that I tried to
It's
pull
coming
it
out
and
easily,
it came
yeah.
out.
Oh, good, good, good.
Pull it came out.
No, in fact, you had already shown this.
You must have deployed the stent at a lower pressure, 10 atmosphere.
No, I deployed nominal pressure.
No,
Because it was
even at 12 atmosphere.
That was the reason why you
because
were able to
LM
pull
was
out.
on a bigger
No,
side.
actually, you are sizing the stent according to the LED. So if you are sizing the stent according to the LED, generally, even if it is trapped, especially the proximal area, you are able to pull out. The problem sometime will be if you have trapped like into a side branch which has an angulation. This was a relatively straight off. So if it is an angulated calcified vessel,
Yeah.
then of course, and also this if you have an ox balloon, ox NC balloon, which is already kind of having a problem at the hinge point, then it could have been a big trouble. But otherwise, most of the time this will come out.
Post dilated, then also you will not be
Then
able to.
Yeah.
High
completed
pressure post
all
dilatation.
the steps
Then
of
it
the
would be
DK crush, and this is the final result. Patient went home hemorrhage. I think this is my take home missing.
So
Be calm, pay attention to your steps. If the patient is stable hemodynamically, even if mistakes happened, think twice before removing any device from the arteries or instrument which can help to prevent the complication.